Thank you very much indeed, and thank you for the kind invite today. My learning points for the presentation today are going to be a very practical presentation, trying to tell you about autoimmune and paraduodenal pancreatitis and to understand the diagnostic criteria for these diseases. Importantly, I'm going to go through some strategies for managing the doubtful clinical situations, and most importantly, I'm going to emphasize the central role of radiology in the area of clinical decision-making. Let me just illustrate with a case. This is a patient who was actually referred to us about 8 months ago, 58-year-old male with painless jaundice. He had undergone CT examination in another hospital, and you can see there are signs there with an enlarged pancreas. The other hospital have felt that he should undergo ERCP for the jaundice, and you can see the ERC image demonstrating a stricture within the lower common bile duct, and he was referred to us for a pancreatectomy due to cancer. Now, we reviewed this at the multidisciplinary MDT, and we felt that the signs here were atypical. And so we went through an algorithm. We actually looked at his serology, and his IgG4 was significantly raised. And we decided, rather than going to surgery, we're going to treat with steroids. And this is the same patient, 8 weeks following steroid therapy. And you can clearly see there's been a marked change in appearance of the pancreas. And the MRCP imaging and the ERCP imaging demonstrates a resolution of the CBD stricture. And so the issue is what decision-making, what points here can we use to actually move away from surgery and actually try and diagnose this type of pathology. Let me start with the background. It was back in 1961 that Henry Sarles wrote the first paper on a chronic inflammatory sclerosis of the pancreas, query and autoimmune pancreatic disease. And this paper came into the literature, and nothing much was said for about 30 years. But in 1992, further paper by Toki, an unusual type of chronic pancreatitis showing diffuse irregular narrowing of the entire main pancreatic duct on ERCP was published, and I show the original image from this, and you can see that the whole main pancreatic duct is narrowed here. From there, papers started being published more and more and more. And this paper back in 1995 by Yoshida basically termed autoimmune pancreatitis as a term for chronic pancreatitis caused by an underlying but unknown autoimmune abnormality. The number of papers increased, and this seminal paper in 2003 basically said that, in fact, AIP was part of a systemic disease based on IgG4 positive plasma cells in both the pancreas and other involved organs. And we now know multiple organs can be involved in this disease. And this is part of a multi-system fibroinflammatory process. The term we're using in 2014 is IgG4-related disease, IgG4-RD. Now, at the same time in 2003, another paper was published in the first publication suggesting there were 2 types of autoimmune pancreatitis based on the histological subtypes. Some cases were being reported from Western countries, which were seen in younger patients with a slightly different clinical presentation and often associated with IBD, and in particular ulcerative colitis. And these different histological patterns have led to the 2 subtypes. Type 1, the classical description of AIP reported by the Japanese, lymphoplasmacytic sclerosing pancreatitis, LPSP, and type 2, idiopathic duct-centric pancreatitis, IDCP. The problem is for all of us is it gets slightly confusing with the terminology. So let me just try to wrap this together for where we are now. So we have autoimmune pancreatitis. We have 2 subtypes within, which are not overlapping. They're separate, but both comprise autoimmune pancreatitis. But it's only the type 1 which is related to IgG4-related disease. And it's the IgG4-related disease spectrum where we're going to see these patients. And in fact, we get other organ involvement in type 1 in up to 90% of patients. Now, as far as the 2 subtype clinical patterns are concerned, as I've mentioned, there are different clinical patterns here. Firstly, epidemiology. Type 1, as I say, is classical, more in the Far East, but actually we do see some in Europe. Type 2 is more European-based than USA. Asia presentation is different between the young and the old, and the clinical presentation for type 1 is normally painless obstructive jaundice with either steatorrhea and diabetes mellitus in some cases, but type 2 is slightly different with abdominal pain and also can present as acute pancreatitis. Gender is very male-predominated in type 1, but equal in type 2. And I've already mentioned about the IgG4, which is significantly raised in type 1. The multidisciplinary involvement as well, IgG4RD is a type 1, as already mentioned, and steroid response will be excellent in this type 1, in both type 1 and type 2. Recurrence, however, is common in type 1, but very rare in type 2. Now, before I mention the imaging, we must understand the histopathology, because it's the histopathology which will drive what we're seeing on the imaging features. And we've got three predominant features. Firstly, the inflammation, which is predominantly periductal in distribution, and it affects the large and medium-sized ducts, and degree reflects the severity of the disease. Secondly, we're going to see fibrosis, replacement of normal tissue, and it can lead to a loss of exocrine function, as I mentioned, steatorrhea and diabetes mellitus. Thirdly, we're going to see vascular changes, and we're going to obliterative phlebitis on both the small and the medium-sized veins. Importantly, intraductal calcification and pseudocyst formation is going to be rare in AIP. So, what about the imaging? Well, if we put the histopathology together with both the pancreatic, parenchymal, and then the ductal changes, we can see a number of features. Firstly, we can get pancreatic enlargement, which is diffuse in about 70% of patients, focal in 30%. Secondly, we get distortion or loss of the normal lobular architecture due to the inflammatory infiltrate into the parenchyma. And this is seen in about 40 to 60% of patients, and it gives us a typical sausage-shaped pancreas. Thirdly, we're going to see changes to the enhancement characteristics, and also a hypoattenuating, hyperintense peripheral rim. And this is a so-called capsule or halo, the halo sign. And I give an example just here. And this, again, is the inflammatory infiltrate and the cells extending out into the peripancreatic space. Peripancreatic stranding is uncommon or minimal. And I show this case as an alternative because you can see it's a very different clinical picture here. We've got a marked infiltrate going out, which looks very different between the case above. And this is another case of a 35-year-old with classical acute pancreatitis. And differentiating the two, whilst on the characteristics here, importantly, you've got to think about the clinical history. Think about the presenting clinical history of the patient to try and differentiate between two types of pancreatitis. I've mentioned about the altered enhancement pattern. Now, this is reduced during the initial pancreatic phase, but in many patients is increased in both the portal venous and delayed phase imaging. And this is going to be very important for the differential diagnosis. We've got unenhanced pancreatic phase, and then we can see an enhancement increased in the portal venous phase and going further in the delayed phase. However, these features, all the features I've just mentioned, will vary depending on the degree of fibrosis, inflammation, and also, very importantly, the length of disease. Are we dealing with an acute presentation or a recurrent presentation in more chronic cases? Calcification, pancreatic atrophy being very uncommon, and I'll come back to that in a moment. Now, what about MRI? I've talked about CT. What about the MRI imaging of parenchymal changes? Well, we've got a CT here demonstrating classical appearances. The patient's got a biliary stent in situ. We've got enlargement of the pancreas on the unenhanced imaging, which is reduced attenuation. And then following intravenous contrast, we've got the so-called halo around the outside of the pancreatic tail and altered enhancement. If we come to the MRI, on the T2 weighted imaging, we can clearly see the slight inhomogeneous reduced signal intensity throughout the pancreatic parenchyma, and there's a low signal halo more clearly seen around the tail of the pancreas. Going to the post-contrast imaging, again we can see this low signal tail, halo around the tail, but also we've got slightly inhomogeneous enhancement in the actual pancreatic parenchyma. Now, we talked a bit on the last talk, so also talked about diffusion-weighted imaging, and there's been a lot of papers published now about differentiating between AIP and pancreatic cancer using DWI. And this was the one paper published in 2010 in the American Journal of Gastroenterology. We can see on the B-value imaging we've got a hyperintense restricted diffusion, hyperintensity within the tail of pancreas, and we've got reduced ADC map involving the tail. And there's been some discussion suggesting whether we can use the ADC values, which we think may be significantly lower in AIP than in pancreatic cancer. The issue being is this hasn't been borne up in other papers, and there's certainly a significant overlap between DWI of AIP and also pancreatic cancer. However, DWI may be able to be used as an imaging biomarker for evaluating response to steroids, treatment response. In this paper particularly, with the ROC analysis, they talked about a significant ADC value. I put it in here as part of the conclusion, but I would say take it with a pinch of salt because there is a significant overlap between the different types of disease. Now let's move on to ductal changes. The most important feature with AIP is irregular narrowing of the main pancreatic duct. And the second most important thing is relative lack of duct dilatation proximal to the stricture. However, the patterns of disease, the patterns of ductal appearance, will vary depending on which parts of the pancreas are actually involved with AIP, with the inflammatory infiltrate. So let me illustrate here. If we take a patient with classical AIP, which is involving the whole pancreas, we get involvement of the whole pancreatic duct, which on ERP demonstrates narrowing and irregular narrowing of the whole main pancreatic duct, and that will be diagnostic of AIP. However, if we have more focal pancreatitis involving the head or other parts of the pancreas, we're going to have involvement of the head, neck region of the pancreas, but relative lack of dilatation more upstream. And here we have a stricture over about 3 centimeters involving the head, neck region of the pancreas, but look, there's not much more proximal dilatation here. If we've got multifocal AIP, okay, multifocal AIP, we'll then get multiple changes here throughout the pancreatic duct. And you can see here we've got various segments of narrowing with slightly irregular side branch narrowing arising from these abnormal segments. From an MRP or MRCP point of view, as I should mention here, over in the Far East, ERCP is considered mandatory for imaging the ductal changes of AIP. However, as Celso Matos already said earlier on today, over in the West, we're obviously going to use MRI and only really use the ERCP for, not for diagnosis, but for intervention. Here we have a patient who's got typical features, enlargement of the talar gland, slightly inhomogeneous signal intensity. And if we look at the post-contrast imaging, we've got the halo around the talar pancreas. And if we come to the MRCP side of things, we can clearly see there's quite diffuse ductal involvement. If I mag up here, quite diffuse ductal involvement involving the talar pancreas and corresponding with the cross-sectional imaging before. Now, back in 2011, a paper was published in Pancreas following a major meeting, world meeting, which gathered in 2010. And this is the International Consensus Diagnostic Criteria for Autoimmune Pancreatitis, ICDC criteria. And the reason for mentioning this is it tries to bring together the strategies for diagnosing these types of patients. And it brings together a number of cardinal features. Firstly, we have the imaging appearance, both for the pancreatic parenchyma and also for the pancreatic duct. And I've just been covering that now. But very importantly, it's not in every case that we can use the imaging features in isolation. We have to put this together with other cardinal features. And for that, we're going to use serology, and that's going to be IgG4 levels and whether they're greater than 2 times a normal. Other organ involvement, which I said in type 1 disease, IgG4-RD disease, is very common, up to 90% of patients. But the key here is getting histopathology. Now, it's obviously very difficult in certain types of patients, and I think there's a very big role to play for EUS. And we've already heard in the other talks about the role of EUS. And we've talked about FNA, but actually now we're able to get core biopsies with EUS, and I think that's going to actually give us a better diagnostic hit rate, particularly for more focal lesions within the pancreas. And obviously the 5th cardinal feature is a response to corticosteroids. Now, within the ICDC criteria, they give a lot of diagnostic algorithms. And I only want you to concentrate on the top 2 features here because it actually starts with the CT and MRI imaging features. In other words, we, in the clinical decision-making process, are key to the management of these patients. We're going to divert, however, we're going to get certain cases, 30% of cases, which are going to be focal AIP. And this is where we come into differentiation from pancreatic adenocarcinoma. Some tricks, tips. Well, basically, I've mentioned about the proximal gland atrophy. And in pancreatic adenocarcinoma, as you'll be aware, and here we have a patient post-contrast, we've got pancreatic mass within the body towards the tail region, and we've got this atrophy and dilatation of the pancreatic duct within the tail, a different morphological appearance. But pancreatic duct occlusion, again, we're seeing this case. I show another case here, pancreatic adenocarcinoma within the neck, proximal body region, and again we've got this atrophy and dilatation of the duct within the pancreatic parenchyma and the duct within the body and tail. Lymphadenopathy is rare in acute pancreatitis around the pancreas, but more common in adenocarcinoma, and obviously vascular invasion is much more common in adenocarcinoma compared to autoimmune pancreatitis. Now, a word here about differentiating from the ductal side. I've talked about the degree of stricture being greater than 3 centimeters, and importantly here from this paper from Ozaki, the diameter upstream dilatation is less than 5 millimeters in the majority of cases within autoimmune pancreatitis. In other words, ductal dilatation being greater is going to be more commonly seen in pancreatic adenocarcinoma. I mentioned about the role of PET-CT. This will give us information both about the pancreas, but also, importantly, on extrapancreatic disease distribution. This is a patient who's got, obviously, diffuse disease throughout the pancreas, but we've also got uptake here within the gallbladder and hilar lymph nodes, which, particularly the hilar lymph nodes, are a common site for extrapancreatic disease. FDG uptake will be seen both in focal and diffuse disease. However, again, there is an overlap between pancreatic adenocarcinoma and malignant lymphoma. Current data suggests this is a useful technique, but again, because of this overlap, it's going to be difficult in all cases to differentiate between this and adenocarcinoma, although, as I say, I think PET-CT is useful for showing disease elsewhere in the body. What about treatment response? Well, again, we've got a patient pre- and post-corticosteroids and changes within the head and neck region of the pancreas, and you can see these have resolved on the follow-up PET-CT imaging. So yes, it can be used for treatment response. Now, I've mentioned in the very first case I showed you that the patient had a stricture within the lower CBD, and up to 90% of cases will have ductal involvement, both involving the pancreatic duct and the intrahepatic CBD. Very common finding, and we get periductal infiltration, as I mentioned, with wall thickening and enhancement changes. Not only can we get this, but we can get other biliary duct features, such as irregular strictures, both involving the intra and extrahepatic ducts, which are more mimicking of PSC. Now, how do we differentiate this between AIP and the normal or classical PSC? Well, normal classical PSC is going to present in patients who are younger patients, normally, and basically are going to have a different clinical presentation when compared to the AIP patients. And very rarely we can get the periportal soft tissue mass, and in this situation, it's very, very difficult to differentiate between this and cholangiocarcinoma. So what about summary key considerations? Range of characteristics, imaging appearances, which can overlap with other pathologies. The diagnosis, as I said, cannot all be made on pure line imaging. However, we've got to use the other cardinal features. But we're going to be using multimodality imaging, including EUS, and the possible role of EUS elastography for these patients. Practical tips and tricks. Well, for you sitting tomorrow back in your clinics, if you see a CT scan suggesting possible features of IgG4 disease or AIP, consider it. Think about it. Even though it's rare, think about the diagnosis. Review the remainder of the scan for other organ involvement, and if you see other organ involvement, this is more clinching for the diagnosis. It's going to be very important for subsequent biopsy. Review previous imaging and histopathology if it's available, and make sure you have a multidisciplinary team discussion, because you will not be aware of all the clinical features of the presentation of this disease, and you need to discuss it with your clinicians to come up with the clinical parameters. And second, and lastly, if you're going to re-image, make sure you re-image following a course of corticosteroids, because AIP has a great response, as I've already showed. Now, in the last couple of minutes, I'm just going to talk about another form of chronic pancreatitis. This is a 27-year-old male with abdominal pain. He's got a known history of alcoholic chronic pancreatitis, and we can see here on both the unenhanced and enhanced CT imaging, we've got a different morphology. We've got changes involving around the head and pancreatic groove here, and also around the duodenum. And this is a patient with paraduodenal pancreatitis. It's a distinct subtype of chronic pancreatitis, which is characterized by inflammation and fibrosis tissue affecting the region between the medial wall of the duodenum and the pancreas, the duodeno-pancreatic groove. However, paraduodenal is an umbrella term, and the term that's often used and you'll be aware of is so-called groove pancreatitis. And I show an example here affecting the duodeno-pancreatic groove. Pathophysiologically, most of these cases have associated anatomical changes with obstruction of the minor papilla. And that is due to various factors, due to narrowing or absence of the ductus anterini, a pancreas divisum, or also heterotopic pancreatic tissue within the duodenal wall. In addition, there have been some cases reported following actual gastric surgery as well. The presentation, clinical features, well, it's very male predominant. The patient has usually got a history of chronic alcohol consumption, and basically the presentation affects the duodenal folds, as I've shown you here, and you can clearly see these thickening of the duodenal folds can predispose to nausea, vomiting, and gastric outlet obstruction. Amylase is only mildly elevated, and at the moment we think there's no clear relationship to other autoimmune diseases. If we look at the imaging features, we can divide it into different morphological appearances. Firstly, we have the solid variant, and this is really a solid mass simply in and around the minor pillar. And here we have the pure form, which I demonstrate here, which we've got a clear demonstration of a sheet-like infiltration of fibrosis inflammatory tissue going into the duodeno-pancreatic groove, and demonstrating inhomogeneous reduced enhancement on the portal venous phase imaging. If we move on to the segmental form, this is slightly different. It's still a sheet-like infiltration, but not only do we involve the duodeno-pancreatic groove, but it also infiltrates into the pancreatic head itself. As far as MRI is concerned, here we have pre- and post-contrast imaging, and on the pre, we can clearly see here that there's actually low signal intensity involving the duodeno-pancreatic groove, and following intravenous enhancement on the portal venous phase imaging, we can see there's peripheral enhancement slowly fills in on the delayed imaging, but overall it's going to be low signal intensity. Now, in some of the patients that present, we're actually going to see another slight variant where we're going to get cysts, either within the duodenal wall, but also within the pancreas itself, or the duodeno-pancreatic groove. And this is the variant, or cystic variant, which fits within the sphere of the overall diagnosis of paraduodenal pancreatitis. And here we have a patient. You can clearly see there's inflammatory tissue involving the duodeno-pancreatic groove with small cystic dilatation. And also, I draw your attention back to the actual thickening of the duodenal folds themselves. On MRI, we can more clearly see the cysts, and we've got a patient here who's got clear inflammation within the head of pancreas and the duodeno-pancreatic groove, and you can see here on the MRCP imaging, these cysts are more clearly identified. Now, I've got to mention here the role of EUS, because again, this is looking to be important for those difficult cases where we're trying to differentiate between paraduodenal pancreatitis and adenocarcinoma. Certainly, EUS looks to be better at showing the cystic changes and also showing the sheet-like infiltration into the duodeno-pancreatic groove. And in some cases, it's been shown that where on CT and MRI, the sheet-like infiltration looks solid, on EUS it looks more cystic, and therefore you have a better diagnostic hit rate. In addition, very importantly, we have EUS with FNA for taking samples to work out the difference between adenocarcinoma. So if you just look at the difference between paraduodenal pancreatitis and groove pancreatic carcinoma, we can see some different features. First of all, jaundice is uncommon in paraduodenal pancreatitis. Tumour markers are going to be normal, obviously, and obviously may be raised in pancreatic carcinoma. EUS-guided biopsy may confirm malignancy, as already mentioned. And ERCP, MRCP is going to show a smooth stricture in paraduodenal pancreatitis, but a more irregular stricture with an abrupt or sharp cutoff in pancreatic carcinoma. Paraduodenal cysts are common in paraduodenal pancreatitis, but two important signs to mention here. The GDA sign, if you think about, because paraduodenal pancreatitis is infiltration, or a sheet-like infiltration of inflammatory cells, you get widening of the paraduodenal space. However, carcinoma is going to be serous-like, it's going to infiltrate in a different morphology, and therefore you're going to get encasement or infiltration of the gastroduodenal artery. In addition, because of this infiltration with the carcinoma, we're not going to get widening of the paraduodenal space. It's going to remain narrowed in most cases with the infiltration going around in a different morphology. So I leave you with a 57-year-old female patient with obstructive jaundice. CT scan clearly demonstrates there's an infiltrative process within the head, but is the widening of the paraduodenal space here? Do we see a low attenuation mass within the paraduodenal space? Do we see cystic change? No, we don't. If I come to the T2-weighted MRI imaging. Again, you've got an infiltrative process going around the duodenum and within the duodenum pancreatic groove, and you can clearly see on the MRCP imaging here that you've got an abrupt cutoff at the lower end of the CBD and the periampullary region. And this was a patient who had a paraduodenal pancreatic adenocarcinoma. So, how do I wind this up? Well, summary. Both AIP and paraduodenal pancreatitis have characteristic clinical and radiological features. But as I mentioned, there is an overlap with other pathologies. And if we're going to make, as radiologists, the best diagnosis, we're going to have to make sure we correlate with the clinical history and clinical parameters of the patient, most importantly with a multidisciplinary team discussion. And I've also emphasized here the importance of post-contrast enhanced imaging to try and differentiate the different pathologies. The field of AIP is very rapidly evolving. We now think there are two distinct subtypes. AIP1 is the classical pancreatitis, which is related to other multisystem involvement, IgG4-RD disease, and we've got to make sure we correlate with other cardinal features for diagnosis. Multimodality imaging, as I've shown you, plays a very important role in the diagnosis and follow-up of both types of chronic pancreatitis information, but as I've stressed here, the most important thing here is to make sure you've got multidisciplinary team discussion, because this is going to be key to diagnosis and patient management. And I leave you with Walter Deming's thing, in this situation, there is no substitute for knowledge. Thank you very much indeed.